Good morning. Welcome to the first Breakfast with the Chiefs for our 2020-21 season. We have a lot of great speakers lined up for this season. I am Matthew Hart, CEO for Longwoods Publishing. I say this every time, but I think it's important. We are always joined by new people. I am a strong believer in building my network, so please feel free to reach out to me at any time. My email address is simply mhart@longwoods.com, or you can easily find me on LinkedIn. We're just about ready to get started, but before we do, I'd like to take this opportunity to thank all of our corporate members. They support these events every year, and I truly want to thank them. Without their support, Longwoods would not be able to produce these events. We have too many to mention all this morning, so please do have a look at them on our website. This morning's breakfast promises to be a great one. We have well over 500 people online this morning. We have a little time at the end for Helen and Matt to answer some questions. Before we get started, a few little housekeeping notes. I wanted to, if you want to ask a question, you'll see at the bottom of your screen a little Q&A tab. Please type in your question there. Matt and Helen will do the best they can to address these, but I can't promise they'll get to all of them. We're limited on time. So I would like to, I'd like to remind myself that you're not here to hear from me. I would like to hand the show over to two of my favorite people, Helen Angus and Matt Anderson.
Thank you very much. I'm going to start off. It's Helen. I'm just delighted to be here this morning, and thank you, Matthew, for hosting. I think last time Matt and I were actually at Breakfast with the Chiefs. We were in a large room at U of T overlooking St. George Street, and so this is a different format, but one that we've actually gotten used to in the last couple of months. So thank you to Longwoods for making this connection virtually. I will look through the list of participants, and it will make me smile to know how many friends we both have in the room. It'll be great to hear from you. We've had, lots of opportunities through our collaboration tables and others to hear, but haven't had an opportunity to talk to as many people as we are going to today. And so hoping that we do indeed have time for questions at the end. And maybe with that, I will turn it over to Matt to lead us off on what we're going to try and cover today. I think COVID might be close to the top of the list. So Matt.
Great, thanks, Helen. Thanks, Matt, for giving us this opportunity. It's fantastic. As always, Longwoods is a core part of our healthcare system. So thank you so much for doing this, and thank you everybody for joining. I know 2020 has been the year of being busy, so taking some time to hear from Helen and I is a real honor. So thank you very much for joining us today. Just a little bit, not everybody would know me. So Matt Anderson, I don't think I can say new CEO of Ontario Health anymore. I've been here chronologically 8 months in COVID time. That's 7 years. So it's been quite an experience. Before joining Ontario Health, I was the CEO at Lakeridge Health. I think more importantly, I was also the CEO of the lead agency for the Durham OHT. And as we talk through the things we're going to be doing this morning, we're going to be talking about COVID, of course. We're also talking about the transformation agenda that Helen and colleagues have put together for the province. And I think what you're going to hear, and I believe what many of you have experienced, is that these two things are actually one and the same. And we're going forward. See, we're having some trouble with Matt to chat, so I'll try to sit more forward. How about that? And I'm just a soft-spoken guy, I suppose. Yeah, thank you, Helen. So just a couple of things in terms of what we're going to do, we'll probably try to do in under 30 minutes, probably in about 20 minutes. Talk a little bit about what we've learned so far, a bit of reflection on early COVID and the response back last spring, what we have learned, and most importantly, sort of where to from here, both in terms of the transformation agenda and our ongoing response, and your ongoing response, and this province's ongoing response to COVID. Just a quick note, obviously we're going to be telling this story from the Matt and Helen perspective. There's many people who have contributed to this. We are 2/3 of the command table chairing, Dr. David Williams being the third. Dave has been a tremendous colleague and all the work that's gone on through public health So lots of people put a lot into this. This is just Helen and Matt trying to give you some perspective as we get started. With that, I'm going to hand it over to Helen to lead us off on some reflections from wave one.
We called this talk the best laid plans because it gave us a chance to reflect a little bit on the experience that we've had over the last many months. And thinking back to last winter, I still have on my easel in my office the last hallway healthcare numbers that we had printed out on a daily basis. And I think about what we were doing. I was working with Ruben and on hallway healthcare and the Premier's Council, Ontario health teams. We were in the throes of, sort of fine-tuning our digital health strategy. Of course, we were working hard on mental health. And so all things that I think actually have ended up holding us in good stead. But perhaps the difference between then and now is we actually got a good night's sleep and a weekend off. It's been a pretty busy time. And then, the world kind of turned on its head. And Matt had the great misfortune, perhaps, of starting on February 3rd. And that was it was exactly a week after we had our first case of COVID, first individual with COVID. That was the 25th of January when we got a call from Andy Smith at Sunnybrook telling us that COVID had landed on the shores of Canada. And so, the good news is that we have people here who had experience. I personally was in the ministry working with Dr. Bell when we had, potential for Ebola and H1N1 and other things. So, we started up the Emergency Operations Center. I do track the amount of time that we spent on this. So I see that we're on situation report 234. So, the apparatus of the Ministry of Health and Long-Term Care Ministry of Health kind of started to ramp up, obviously, well before the declaration of an emergency on March 17th. And by the end of February, we had the first health command table in its most formal sense. And we were well on the way to coordinating this health system response. I do recall that in February, a lot of our focus was actually on the repatriation of Canadians who found themselves overseas or on a cruise ship in through Trenton. And of course, Matt was there, kind of every step of the way. And I think, I think we had one meeting when we kind of thought about, the whole potential of Ontario Health. And clearly, we had all the legislation and the, accountability mechanisms in place and mandates and everything else that we had worked through with the board. But, we were trying to figure out how we were going to, relate to each other in this new world. Very excited about the possibilities of having a strong agency. And then kind of boom. And so we had to work together immediately and intensely on a whole variety of challenges that neither of us, at least certainly for my part, had ever faced before. So, it worked well from the beginning. And I think, grateful that we actually had, such capable leadership at Ontario Health. And it certainly kind of went from getting marriage pretty fast in terms of working together on the COVID response. So maybe Matt, you may have a different view of this than mine, but perhaps I'll give you a chance for your reflections.
Yeah, thanks, Helen. I think I would just add a couple of things, and it was quite something for me coming in, for sure. I think probably the reflections that I would add is how quickly and really wonderfully the field responded to what was happening. And so not only for Helen, as we got our subtables up and going, and experts from science and clinical and all kinds of stakeholders from across the system and elsewise, and certainly in the broader ministry sense, in government sense, but also in the field, a huge shout out to Dr. Andrew Baker and the team who got our critical care command center up and running so quickly. One of the decisions that was obviously the most significant for us early on was the decision to shut down elective work to create capacity in the hospitals in anticipation and looking at what we were seeing in the other jurisdictions who were battling what was going on with respect to COVID. And also, more several things that are still with us today. So assessment centers, suddenly, particularly hospitals, found themselves in the assessment center business, and we had to get that up and running very, very rapidly. And even today, as we see a new surge into our assessment centers and the things that we're going to need to do there. So, all of that, the credit sits with the field. Amazing people who did amazing things, and the list could go on. I know we're going to talk about a couple of other things, and in particular, some of our lessons learned, but just to shout out what those folks were able to do. Also a big thanks to the folks in public health, their response. And I think one of our key lessons in all of this and continue to work on is how do we continue to weave public health with the rest of the healthcare system, something that in some parts of our province was already well set up and well established. In other parts, through COVID, we've really started to move on that. So there's a number of things. Lab network, we didn't really have a provincial lab network back in February and March, and so we've had to create that very quickly. Again, those at the end of the day, that's the labs, the PHO labs, the hospital labs doing fantastic work, and the MLTs and all the clerks and everybody pulling together. So, this response, although Helen and I are here to talk a little bit about it, at the end of the day, we both recognize this was a field response and an industry response to an unprecedented challenge.
Yeah, thank you. I would say, one of the things that one of my reflections is the effort required to secure access to PPE and otherwise equipment. So think, N95, respirators, ventilators, it's been it was certainly challenging. And back in March and April, it was a sort of 24/7 exercise to try and secure supply, largely based in China, and pursuing hundreds of leads. We have an Ontario Together portal that basically takes any good idea and runs it to ground in order to secure supply. And today we're in a completely different place. You've seen, domestic supply, whether it's gowns, ventilators. We're going to be making N95s in Brockville. We've just let some tenders to do surgical masks in Ontario. The winner of the first round will have to have manufactured surgical masks available for us in October. So, we're much less reliant on supplies from overseas, and the Premier was pretty clear about that. So it's been an interesting partnership, obviously, with not only with, the field, the health sector, but also with our colleagues inside government, whether it's a government services or economic development. So, I think that, a lot of mobilization inside government to try and, work across to solve challenges proposed by COVID. Certainly, we mobilized resources and logistical support to support vulnerable populations, across congregate care settings. I would say one of the highlights for me is virtual care, and certainly, introducing the K codes for physicians and others in the early part of the pandemic, has really changed, and I think it's one of those things that we'll never go back to. Although, we find ourselves now with a deficit of some important preventive care, procedures, whether it's Pap tests or some immunization. So we have to hit a balance of virtual and in-person care. I think Matt's already talked about the lab system, and we certainly went from being challenged to actually the leading Canadian jurisdictions in terms of the numbers of tests done per day, getting the COVID test results online, And certainly the app, I do check mine daily, but I think we're over 2.6 million Canadians are using COVID Alert. So it's just it's been a remarkable effort from where we sit, and of course, certainly the part of the system that probably has been the most challenged is our public health partners. They've been on the front line of this, from the beginning, and providing careful guidance and leadership, and certainly been, ambassadors to the public about, how about the virus and how to stay safe. So I guess, my final comments here would be about, how engaged the Minister of Health has been in the response. And there really is, we can't have asked for better leadership on than what Mr. Elliott has provided to us. She's, on call after call with the team. I would say Minister Elliott and the Premier drop into the command table on a somewhat regular basis. We hear from them when they're happy. We certainly hear from them when they want us to move a little faster. And so hopefully we're delivering on the Premier's commitment. And I think many Ontarians watch the 1 o'clock presser. Sometimes we actually get to watch it ourselves and see the kinds of questions that are being asked by the media. And certainly, I think before I turn it back to Matt, certainly want to congratulate him and the field on the regional COVID tables. They were an enormous and continue to be enormous support. They were stood up very quickly, working with hospital community partners and others on the response. Supporting work with vulnerable communities. I think about the work done in southwestern Ontario with the farm workers and providing accommodation and support to them on very quick order. So perhaps Matt, you may want to comment more directly about that.
Great, thanks, Helen. So for sure, and a thank you again to so first to the folks at Ontario Health. And the teams that came together. And I mentioned in the get-go that having come from being a lead agency of an OHT in Durham, this whole notion of local coordination up to the regions and then up to the province was core to the response of COVID. And when we think about, and I said earlier in the conversation that there's the discussion on transformation, there's the discussion on COVID. A lot of those things were happening simultaneously. And my overall observation would be that on that is that although structurally we had to hold back on some of the things that we need to do at Ontario Health, and if I get a moment, I'll chat a little bit more about that. But a number of other parts of change emerged. And certainly the local coordination, the coordination with public health, up to the regions was a key part of our response, and it was a key goal. And I would say that we've probably matured that up very, very quickly, far faster than would have. I prefer to not have that, but it certainly has made a big difference in moving up through regional. Supply chain distribution is an easy example of that. Going into this back, whatever was a sort of supply chain distribution network out to all players in health and even beyond health, and through the regions and through the local teams, we now have that. So that's a wonderful thing that we were able to put together. Again, challenging times in terms of where we were trying to go. If you're all right, Deputy, I know we're going to talk a little bit about some of the lessons learned. Would you prefer to go to lessons learned, or
yeah, no, I think we should do that.
And maybe I can make a few comments about Ontario Health. Hopefully, out of the 500 people online, there might be one or two who are interested.
Yeah. Go ahead.
Oh no, let's do lessons learned first, and then.
Okay. Yeah, so I think well, for me, I guess collaboration is absolutely the collaboration that we were trying to achieve through Ontario Health teams, and I know that we've actually are continuing to do the work and announce more Ontario Health teams that really kind of put us in very good stead, and that certainly the idea about working collaboratively across sectors on common problems, which is kind of the fundamental idea behind Ontario Health Teams, is the right idea, and certainly I think has helped us, in vivo in the pandemic response, and how people stretched, beyond their borders to solve, challenges, and being nimble, and certainly deploying resources, across sectors to where there were problems. So the willingness and to collaborate on the ground, I think, is a lesson learned and a strength of the healthcare system. If I think about, where we probably, need to improve in the second response, and I do think we're much more ready for what increasingly, looks like a sustained increase in numbers. I think, we're going to hit another day over 300 today. So that gives me angst. But I think, trying to understand roles and responsibilities, we're certainly in a better place than we were. There are a lot of actors in the response, right, Matt? We had the ministry, Ontario Health, public health units, individual organizations. For me, in particular, I had a line of sight and had to work across with other ministries, whether they were, providing money to municipalities for accommodation, or other supports that weren't from the healthcare. We had a critical workforce committee in my colleagues in corrections. So I just think that we have a much clearer sense, about how to lead an effective response, and we've been able to form up into incident management structures fairly easily, and have a pretty good idea about when and how we would use those structures to really drive action, both inside government and beyond. So those are some of my thoughts.
I think I'll just add a couple. For sure, echoing the rules. We certainly heard a lot back on that, and how do we sort of quickly make decisions, particularly in areas, when I compare sort of the traditional healthcare response and sectors, I think that's something that we sort of know how to mobilize quickly. When we got, the further we got from sort of the center of the traditional healthcare system, I think we found more and more challenges of how do we make that decision making slick and quick and get those pieces moving. How do we empower at the local level? And I think we did a good job on that, but certainly more to be done as we move that forward. And even the messaging, both Ontario Health and the Ministry of Health did focus groups over the summer on lessons learned, and a lot was around this idea of how do we make sure that our messaging is all consistent. I was in the fray. We were getting a lot of messages out there. I know a lot of organizations were receiving multiple messages a day, and we have to tighten that up as well. So we want to do that for sure. And you already mentioned, Helen, the congregate setting environment, whether it's long-term care, the corrections, retirement homes. How do we move very, very rapidly? One of the things I think was an important learning for me in particular is COVID is not like other diseases. It seems to move a whole lot faster. Now, I'm not a doctor, in case you haven't heard that. But from a non-doctor perspective, looking at how quickly the disease moves through these settings, again, picking up our ability to respond fast is also one of the keys as we get into this next wave.
Yep.
Do we want to, Helen, before we move to, I can see there's some questions starting to pop up in the chat. Before we move to questions, a little bit on OH transformation from here. Would that be?
Yeah, I think people are curious about how Ontario Health is sort of becoming itself. So why don't you go ahead?
Great, thank you. So, and as I said, there's sort of a big overlap here between what we're talking about on the transformation agenda for Ontario Health and also in terms of our COVID response. And I'm just going to pick apart. Some of you may know that we just recently released an operating model and an organizational chart. First ones, this is a whole world of firsts for Ontario Health as we try to move forward on things. And I'm just going to highlight a couple of points on it. For this audience, I don't think that these would be shockingly new, but they are important nuances as we think about how we're evolving ourselves. The first is this real focus on not just patients, but residents, communities. We've got various different communities within communities when we say that, and a strong encouragement from our ministry partners to ultimately be focusing on population health and the quadruple aim. So we took that very seriously as we think about how do we move it forward. Also, a very important acknowledgement that most of what we'll be able to do through Ontario Health is going to be done through our partners. Ontario Health, with only a few exceptions, work directly with patients and communities. We do that through our providers and supporting our providers. And so we've drawn this as a hierarchy with our communities at the top, our providers, and then Ontario Health supporting that. And again, one of the nuances there and one of the lessons from our time through COVID, that as we think about who are the partners of Ontario Health, particularly on the delivery side, we're talking beyond the traditional hospitals and primary care. Obviously, those are folks that we need to work with very closely, but we deliberately and specifically called out social services, so housing, schools. We've certainly been in those areas through the LHINs and through other means, but really making that absolutely clear. And then the last one that I'll comment on in terms of the change or the direction for Ontario Health from here is really about our regions. And there's been different speculation around what's going to happen with the regions. Our regions are our front door. In fact, everything that we do at Ontario Health is to support those regions, because the regions who are going to support our providers, who in turn are the ones who deliver the care and the support and the education to our communities. So just embedding that, probably not shockingly new thoughts to the folks who are on this call, but really trying to embed that into what we do. We've created an org chart. The org chart, I think, is less relevant. The more relevant is this concept and ethos around our operating model and how we're going to support our colleagues in the field as they do the wonderful work on the front end. So that's underway now. We've got a fair amount of work to do. As I've said, I think through COVID, it certainly has impacted our ability on a structural level in some ways to move quickly. Culturally, I think Ontario Health is very different than where we were at the beginning of COVID. When I arrived and the couple weeks there before the pandemic sort of took over, we were 21 agencies, largely trying to learn who each other was. And in a very short time, we had to work together to move very quickly and very rapidly to support our communities. And so from that perspective, I think we've made some great change. Lots more to come on Ontario Health, and I could go on for a while, but we're almost at 9:30, Helen. So I think I'll probably just stop there and hand it back to you for any last words, and then perhaps we can get into the chat.
Yeah, my suggestion, I think let's just get to some questions. There's questions both in the question box as well as in the chat. So maybe if you've got them open, maybe we could start looking through some of those and see whether we can answer them. The first one there on the question and answer is about your suit, so that's good. It is nice to see you dressed up.
We're starting.
Most of us, some of us, we've both been in and out of the office, like probably many people. Since we're not doing as many face-to-face meetings.
Yeah, that's for sure. There's a question on transformation and development of OHTs and LHINs. I don't know, Helen, if you want to do a quick reflection on sort of OHTs, and I'm happy to just take that a little further. I did comment on it a bit, but we could take that.
Yeah, I don't know that we have data, but what we hear from the field is where we had Ontario Health teams and people were meeting and working together around a common set of goals or a population, that those relationships were helpful to the COVID response. And that it was an easier kind of jump to sort of see themselves as collectively accountable for the health of a population, whether or not they were the specific provider of, for example, long-term care. So that to me, is a really, good thing. And, people continued to work in Ontario Health teams during COVID response and advanced their proposals into the ministry. So I think, that shows to me that it has traction and value. and hopefully that will continue. I think it's anecdotal at this point. I'd like to see, did it make a measurable difference, in the very early days of Ontario health teams during the pandemic. But I suspect, that what I'm hearing is, has some validity, and I guess that's encouraging. And I think, the transformation of Ontario Health, hugely important to us. Having, one entity with regional offices. I mean, it just, you're moving into command and control kind of structures, right, Matt? And so being able to go from direction to implementation much more quickly without having 14 boards and independent actors and other things. I think it made us, or helped us get traction on the ground a whole lot faster than we would have under the previous construct.
Thanks, Helen. I'll make one comment on this, and then I noticed there's one of the themes going through is around surgery and getting at the backlog. So maybe I'll make one comment on this, and I'm happy to take the surgery, take a shot at the surgery backlog question, and we'll get some other ones in here. So just one additional comment I want to make is just a shout out that LHINs at times have been a four-letter word around the healthcare system, and I think that through our COVID experience, the response from our team in the regions was absolutely phenomenal. These folks, in many instances, put on masks and put on gowns and went in and did the work. And so just a great response. And I think really, I hope, certainly a lesson to me, I hope a lesson to the whole system on how important this regional structure and how effective local and regional, the more that we can push decision making down into those areas, the better off we're going to be. And again, coming back to the operating model concept of, the center should be supporting into the region, not the other way around. So hopefully we'll see that continue. I'll make a quick comment on surgical and procedural backlog. That's something that is on everybody's minds, and certainly something that the Minister of Health has been talking to us a lot about. The short answer is that with the support of the ministry, we are looking at ramping up as fast as we can to do extra procedures and to try to get at that backlog. Right now, things are going well in terms of getting that back up and running and getting our hospitals online and able to do that. And I don't want to, not only hospital care, but it is procedures and surgeries. A key part of this, of course, is going to be our community's response to the growing numbers on the COVID side. We really don't want to get into a place where we have to sort of ramp down in the hospitals. My colleague Rod here has asked a question about community-based, and that's exactly right. How do we try to rely a little less on the hospitals, make sure that they have that opportunity to go after backlog of cases, and at the same time provide the kinds of supports that we need out in the community. A couple of different strategies are coming on board on that. I've been taught by my great colleague, Deputy Angus, to never scoop the government, so I won't. But there are some other strategies that are in the works to see if we can start to spread out some of this demand more across at a community level as compared to necessarily exclusively at a hospital level. So we are doing that. And one last comment I'll make on that is that we also want to, some of you may have seen there's an excellent paper done and was published last week, got some coverage in the news just around how long it's going to take and how to go against that. A number of folks who contributed to that are part of Ontario Health. And so now we're comparing sort of our notional approach and what we've talked to the government about in terms of where we can go against that to see, can that become a little bit of a measure for us? Can we beat it, basically? Is there a way that we can figure out how to move that forward even more quickly? So definitely top of mind as we try to get it all caught up.
Yeah, so maybe, Matt, the corollary to that is, what do we need to do differently in wave 2? And I see some comments and also in the chat about, making better and fuller use of our community capacity, primary care particularly, but obviously home care. And that's, certainly I'm hoping that our fall plan will be, ready for public consumption next week. But the idea of, engaging with primary care, getting more people to go back to their primary care practitioners, for the regular care that they need, as well as even, I go back to the guidance that Public Health Ontario has issued about, what kind of swab to use. It can be used, if we're using nasal swabs rather than nasal pharyngeal swabs, we can use a more diversified workforce. We can probably do it in more places. So I think all those things are different, and I think we need to work with our primary care and community partners really to make sure that they're working, as an integrated part of the response. I know that there was a really good document on primary care that was released. I believe it was David Price who brought it to the command table, but as sort of the leading of our primary care group on our response. But many of the organizations are in the room: RNAO, OMA, OCFP, and others. I think were involved in that, sort of trying to provide some guidance to primary care. So they can feel sort of, more comfortable getting back to the office. And certainly we're having discussions with our home care partners as well about stepping up. And I think there's some really good ideas about, more intensive home care than we probably ever offered before. And I think, those are great ideas, and we're looking, to implement those so that we can really provide an equivalent level of care in the home, and, keep the social distance within long-term care facilities, as well as and try and keep our ALC numbers down. So that's a large task, but I think we need all those partners to work with us to achieve those goals.
Great. Helen, there's a few questions around long-term care and readiness. Now, Richard's not here to comment on that, but you want to make a couple of comments on that one, and I can also echo on that. Also, there's some comments in here around virtual.
Yep.
I'm a little biased on that one. I'd be happy to.
Okay.
And also a little bit on here about, which is a wonderful comment around what are we doing around to stop racial injustice, and where does that sort of play in what we're trying to do, I think even beyond what we're doing on COVID. So a whole menu up there. Helen, why don't you take your first pick of those, and then I'll pick a few too.
Yeah, so, I know that there's been we're part of a planning and recovery group in long-term care. It's chaired by Tom Stewart and has long-term care partners. So, a lot of work has been done over the summer. If there's a PPE problem, I see from one of the comments, we should follow up on that directly, because that should not be a problem. And there is sufficient PPE in the stockpile to be able to supply long-term care homes. So that's a problem. I do think, we do know the pattern. With an uptick in numbers, it doesn't take very long for COVID to show up in a long-term care facility or retirement home or other congregate care settings. That those vulnerable people, of course, will be, a big concern. We're trying to develop responses that don't necessarily have, the first call to the hospital. Public health has been, actively deployed, providing IPAC and other supports. And I think we have a range of options about how to isolate residents into three groups. Those how to basically prevent the spread, doing it in a disciplined way. I think the IMS structure that we put into place in the spring had allowed us to really kind of get to a much better place pretty quickly in long-term care. I certainly would think that we will want to use a similar kind of structure now, just to make sure that there's absolute discipline on the things that should be done are actually done inside long-term care homes, and that we're really working collaboratively to make sure that we're absolutely doing everything possible. I know that the health sector will step up again, as they have. The challenge here is not to impact those elective surgeries that the scheduled procedures rather, that really need to be done. And I think there's some innovative ideas about how to deploy additional capacity to long-term care in ways that may use the support of hospitals, but also others. So perhaps we can ask Richard to follow up on the comments, but there's a kind of full court press. The situation in Ottawa is obviously incredibly concerning, and we are working very hard. I think you'll see, there's been lots of action already, and more to come in the coming days.
Thanks, Helen. Maybe just in the last few minutes that we've got here. So first, I'll just do a quick ad. We're not really ad, but just there's a lot on home care and community care. I know Helen has commented on that, and myself as well. And clearly continued press there. And we'd like to see through a bunch of different means not have the numbers drop like we saw last round, and keep those numbers up in terms of supporting people in their homes. Obviously, that's a major strategy for this, and particularly for this type of disease. And so can we avoid that from happening as it did in the first round last time? On virtual care, so many comments and questions around virtual care. So I'll just try to make some sweeping sort of comments on this and hopefully catch a bunch of it. First is I would just say a huge acknowledgement to the Ministry of Health and to our government for opening up codes and really opening up our opportunity to truly embed virtual care into what we're doing. We've seen more pickup. For those of you I didn't go all through, mercifully I did not go through my entire background for you at the beginning of the event, but my start was in IT and in virtual care, and this is so near and dear to my heart. And we've accomplished more in the last 6 or 7 months than we did in years prior. And I'm confident in speaking for Helen that the government is totally supportive. Helen is personally supportive of continuing to grow our virtual care. There's a number of things underway. We saw a lot of that coming out. So there's a lot of specific questions around pay codes and all that sort of stuff, and just time won't let me be able to get to all those, but we just recognize that that is a major part of what we're moving forward on. Maybe what we can do, I don't know if this, we got about 2 minutes left there, Helen, on the aspects of racial injustice, diversity, anti-racism. Maybe I'll make a comment and then I'll hand it over to you, Helen. For us at Ontario Health, we have this really unique moment in time where we are creating a brand new agency. And so backing up for a moment, for those of you who don't know exactly how this has come about, we've got 21 agencies that are all merging into ultimately one agency. And when you have 21 merging into one, it means that we're starting from almost from scratch, if you will, on our policies, our processes, how we govern, how we manage. It's not like I've been part of many mergers where it's one agency moving into another and you sort of augment the existing policies. That's not where we're at. We're actually have this as clean a slate as you're going to get, which is a massive opportunity for us. We have brought in some external help. We have some agencies who've got a very rich history in this, including HQO, Cancer Care Ontario. Many of the LINs have done a tremendous amount of work on it. So this is front and center for us, for our board, our top priority as we think about how do we pull this together. And again, an exciting time for us at Ontario Health because we are at that beginning stage. So I'll just leave those comments there, and Helen, maybe give last word to you on this one.
Yes, and the same kind of experience. I think, a couple of things. Obviously, we've started to collect race-based data, and looking forward to, I think the data quality is improving, so we'll understand more, and that kind of relates to the data platform issues questions as well, but really understanding the impact of COVID in the healthcare system and making sure that we're being attentive to the structural dimensions of this and the vulnerability of certain populations. I think one of the things we're doing at home here in the ministry is really paying attention to culture, to systemic racism, microaggressions in the workplace, looking at any workplace harassment issues that have happened. All organizations have them, but I think it's particularly important that a public organization, whether it's Ontario Health or the Ministry of Health, reflect the population that we serve, and that we are a place where diversity thrives and is part of the fabric of our organization. And so we have at the Ministry of Health for our employees, a whole plan of active listening, engaging, and co-design in order to make sure that opportunities for Black and racialized workers are as plentiful as they are for everybody else. And I think as we pay attention to this at home, we'll probably be better in our interactions and expectations of the health sector. So we take it pretty seriously here, and I'd be happy to share with any organization, kind of how are we dealing with this in our workplaces, so that our employees and the people that we serve can feel like we're attentive, because we're living in obviously pretty dramatic times, and I think it's time that we call attention to that issue in a more structured way in our workplaces.
Great.
I see Matthew back on the screen there.
Just before you wrap it up, Matt, I do just want to comment. So first off, thank you for everybody coming. And I know there's just a ton of questions coming through, and we'll try to find other venues to answer some of them. Very, very helpful. I would also just want to do a quick shout out, because there was a couple comments on there about mental health and addictions. I had a whole section on mental health and addictions in my notes.
Yeah.
So, and maybe another time, maybe non-COVID time, happy to come back and talk about our mental health and addictions program, and certainly where we're going with the Center of Excellence. I know that's of great interest. So I'll stop there. Thank you.
Yeah.
Helen, Matt, thank you so much. It was wonderful to hear from both of you. These are still new venues for Longwoods, our speakers, our attendees. I think it's going well. As mentioned at the start of this morning, we have a great lineup of speakers coming up. Our next event is October 21st. It will be featuring Rick Glazier, who is the Scientific Director for the Institute of Services and Policy Research at the Canadian Institute for Health Research. Registration should be opening up in the next few days. Other than that, I would like to wish everybody a wonderful day and look forward to next time. Take care.
Thank you.
Thanks very much.